Hello friends, welcome to Shri Netralay. The initial steps of this video are slightly fast forwarded to save time. 2.6mm main incision, 23 gauge side port, followed by a 5.5mm rexis which is perfectly performed with a cystitome, and hydro is performed with 27 gauge cannula. And once this is done, we will go with the phacoemulsification. This was not a big deal surgery, grade 2 cataract, not very complicated, well dilated pupil and a very good situation. And here I go with the left hand dialer and right hand goes in for phacoemulsification. A small amount of debulking of the nucleus followed by removing the cortical material, and the first crack goes in. This was followed by the second crack of the heminucleus, and without further division I am taking out the first piece of one quadrant, followed by the removal of second quadrant with the help of phacoemulsification. Now dividing it further, the remaining heminucleus and taking it out easily was not a big deal at all. This was followed by cortical wash, and my left hand is out to prevent any PC rupture, first followed by right hand removal. Anterior chamber again is formed with viscoelastic. I usually use a coaxial irrigation aspiration cannula to take out the cortical material, and this cortical material is taken out within seconds. And now we are implanting our IOL in the bag. The leading haptic has gone in. The trailing haptic is dialed into the bag with the help of IOL dialer, which is having a blunt tip. But now what is this tuck sound has come, and how that sudden movement has occurred? Even I am also not aware that something has gone wrong, and I proceeded with my visco wash. As soon as I gone in, I am washing the visco from the anterior chamber. You can listen to the background noises, which was like a very good situation, and we are having some conversation about the particular case. And as soon as I entered behind the IOL to remove the viscoelastic material, I noted the folds in the posterior capsule. There is no reason to have posterior capsular fold in such scenarios. Now note, my right hand is there, left hand instrument I have taken out, and I asked my assistant to give me a 2 ml saline syringe so that I can form the anterior chamber well. It is extremely important for such scenarios. Do not take your instrument out. Keep your irrigation on so that anterior chamber remain formed and the PC will not rupture further. And with the left hand again I am forming the anterior chamber while taking out the irrigation aspiration probe. And note, while taking out this probe, even while this particular moment I am not stopping my irrigation aspiration, and this way my iris has come into the main port, sealing it, and the anterior chamber is well formed, and thereby preventing further progression of PC rupture. This is a pretty controlled situation for me. I am having a posterior capsular rent there with IOL in the bag, and the rent is not too big to cause dislocation of IOL, and chamber is well formed and main wound is sealed with iris. I form the anterior chamber, do a hydro for the remaining of main port, and form the anterior chamber slowly without causing any collapse of anterior chamber, and thereby prevent the PC from rupturing further. This is a toric IOL, so IOL is rotated in a proper place, and that completes the surgery. So let us rewind the situation again and see what has actually happened. I have dialed the trailing haptic in the bag, and till now everything was okay, and I got a sudden jerk. This sudden jerk has pushed the eyeball to one side, and the instrument was almost vertical while this situation was there and it has inadvertently caused the posterior capsular rupture. While seeing this in a very slow video, I can note that it has caused a PCR, and we can once more see it with a 0.1x speed, so then we can realize what has actually happened. So this particular thing has happened in less than 1 second. Let us see it again. This left hand jerk has caused by myself. I was throwing away the injector which was having in my right hand, and that has inadvertently touched my left hand while throwing it away to the dustbin. So that is a mistake which has happened and caused this particular incidence. To highlight the importance of such scenarios, I have posted this video. And see, once this has happened, the good part of story is I don't have such a large PCR so that I cannot place the IOL in the bag. Once you have this situation, it is very important not to take the right hand out and
Okay.
keep the chamber formed. And I
Sorry.
asked my assistant to give me a 2 ml syringe to form the anterior chamber. My iris was helping me to keep the anterior chamber formed, and thereby I could salvage the situation
मला
very
height
well.
बोलले.
The patient is doing extremely good in a post-operative period, and there was no vitreous disturbance luckily. So I hope this particular situation will help you understand the scenarios which can happen in the OR suddenly, and you have to be ready for all situations coming forth. Do subscribe to our YouTube channel Dr. Pankaj Lande for more such exciting videos. Good day.